Well, we are honored to be here with all of the great leaders in our industry. So what we're going to do today is take all of that complex biochemistry and try and break it down into something that's easy to understand, not so scary, and something you can put into clinical practice. Our faculty disclosure is that we co-own Zebra Diagnostics, which is SNP Ed, and we receive compensation for doing so. We're basically going to go over methylation, folate trapping, neurotransmitter synthesis, homocysteine catabolism. We basically want you to understand that functional testing is incorporated into these genomic SNPs. So we don't just look at a SNP and say, hey, they have this, and therefore X is going to happen. So we're going to jump right into what is methylation. So simple, right? We want to think of methylation as one carbon, 3 hydrogens, and the process of methylation is simply moving that methyl group from one compound to another. Now, there are lots of forms of epigenetic activation. We're only going to be covering methylation because we don't have all year to talk about it. So this is the typical representation of the methylation cycle. It looks pretty complicated. What I want you to take a look at, and can you guys see the cursor on the board, is this is the methylation cycle here, which is basically a B12 or methyl recycling group. So if you start thinking of it that way, it takes all of the teeth out of the scary biochemistry. The folate cycle is also a folate recycling center. So, and how these things interact, we'll get into later. Over here is the Biopterin cycle, so this is your neurotransmitter cycle, the urea cycle, which unfortunately we don't have time to get into today, and then Transsulfuration, which is a fancy name for homocysteine catabolism. This is an easier picture to look at. Again, we have the methylation cycle, the folate cycle, Biopterin cycle, urea cycle, and Transsulfuration. But here in the middle, we have what I call our celebrity SNP. Everybody knows about methylene tetrahydrofolate reductase, right? Yes, heard about it, thought about it in practice, okay. So it makes sense why it's involved in the folate cycle, because its purpose is to make methylated folate so that that methyl group can then be donated over to the methylation cycle via an enzyme called MTRR, which is methionine synthase. What's not so clear is why MTHFR intersects with the Biopterin cycle. And the reason that it does this is because it is the substrate for tetrahydrobiopterin, and in certain circumstances, methylfolate can actually stand in for tetrahydrobiopterin. So what does it do? MTHFR, it catalyzes the conversion of 5,10-methylene tetrahydrofolate into 5-methyl tetrahydrofolate, a co-substrate of homocysteine remethylation to methionine. I'd like you to say that 10 times fast. What it really does, as I said before, is make methylated folate. And this is important because our usable form of folate in the body is tetrahydrofolate. It's not necessarily methyl tetrahydrofolate, which is what we all seem to go for. So when it donates that methyl group over to methionine synthase, it then turns back into tetrahydrofolate so that it can participate in that cycle. So for visual learners, well, let's go back. Well, where did it go? Sorry about that. Okay, nope, we skipped one. That's what happened. Sorry, excuse me about that. So there are 2 variants that we look at. It's MTHFR C677T and A1298C. You will notice that C677T has a higher degree of disability, whereas if you're homozygous for that location, you're 70% loss of function, versus at A1298C, it's only a 40% loss of function. They both have the same cofactors of riboflavin and NADH, whereas one is associated with mood disorders, the other is associated with increased levels of homocysteine. If you happen to have an alteration at both loci, then you'll be called a compound heterozygote, and you'll have approximately 50% of loss of function. Now for my picture. So here we have tetrahydrofolate being converted into 5,10-methylene tetrahydrofolate. And that actually occurs by an enzyme called serine hydroxymethyltransferase and has a cofactor of vitamin B6. And then 5,10-methylene tetrahydrofolate gets converted into 5-methyl tetrahydrofolate. Over here, again, is methionine synthase. So the most common form of cobalamin in the body is adenosylcobalamin. But for methylation, we're going to need methylcobalamin, right? So we need to borrow that methyl donor or steal that methyl donor from 5-methylfolate. So then it goes on through the methylation cycle to methionine and homocysteine. Keep in mind, homocysteine is simply methylated methionine. So I'm trying to defang all of these complicated words. So if you start thinking about a methyl group moving around, all of a sudden the words start to make a little bit more sense. So the reaction of MTHFR is irreversible. That means we cannot go from 5-methyl tetrahydrofolate back up to 5,10-methylene tetrahydrofolate. So again, let's defang it. What is the difference between tetrahydrofolate and methyl tetrahydrofolate? It's a methyl donor. And again, it gives that methyl group over to methionine synthase. So if we have 5-methyl tetrahydrofolate and there is a lack of cobalamin in the body, what do you think is going to happen to that extra methylfolate? Is it going to go and collect $200 and go onto the methyl cycle? It's not. It's going to get trapped in this version of 5-methyl tetrahydrofolate. So this means that a deficiency in cobalamin can actually result in a functional deficiency in folate. Let's look at this a little bit closer here. So we have tetrahydrofolate, which is our substrate, 5,10-methylene tetrahydrofolate, which is our substrate for MTHFR, and then we have 5-methyl folate. You notice here there's a big X in the center. What happens when we cannot pass that methyl group over is that we have a decrease in methionine. We have a decrease in protein synthesis, a decrease in cellular methylation, a decrease in methylated methionine, a decrease in homocysteine. We also have a further decrease of glutathione and an upregulation of our free radical forming oxidants. So when you are not able to pass that methyl donor off, you have a whole downstream of complications. So if you add more folate into the system, if there's an alteration in serine hydroxymethyltransferase or MTHFR, did at any point I say that there was 100% loss of function in those enzymes? No. So those enzymes are still going to participate in that action and still create methylfolate, even if it's not the amount of methylfolate that would be optimal. So again, this is why we have a functional deficiency in folate, because our folate marker for functional testing is tetrahydrofolate. It's also going to mask B12 anemia, and it's why we always check for B12 levels before dosing folate. So in summation, the only acceptor of that methyl donor is homocysteine. Methionine synthase is actually the SNP that you want to be investigating, not MTHFR. B12 deficiency, is it only caused by MTR? No, it can be caused by many, many things. It can be caused by Concerta or other drug reactions for PPIs. It can be cobalamin transport issues. There are lots of reasons. So I want you to not automatically assume that, okay, we have the cofactor for methionine synthase B12, it must absolutely be that. So clinically, when someone is folate trapping, there are labs that we're going to look at. There's methylmalonic acid, which is a functional marker for B12 deficiency. So when methylmalonic acid goes up, that means that B12 levels are going down in the cell. The same thing for form-aminoglutamate or FIGLU. If those levels go up, it indicates that there is a decrease of cellular folate. Now, for those of you who look at serum folate, you will notice that there is an extreme elevation of serum folate. So most of the time, you'll look at this and go, oh, they've got plenty of folate, it's fine. But unless you look at those functional markers, you will never know that this person is folate trapping and having all of those downstream issues. The last thing is that they're going to have decreased homocysteine. So this is the opposite effect of MTHFR C677T, where you have an increase in homocysteine. So people automatically think that folate metabolism, one-carbon metabolism issues are all MTHFR. I need you to think outside of the box and look over into the next cycle of transsulfuration. Let's put this into practice. We have a 50-year-old woman who has a history of miscarriage and recently had a non-fatal heart attack. You check her CBC and it's elevated. So the first thing, as clinicians, we need to stop and think, okay, are there conditions associated with her presentation, right? So miscarriage and cardiovascular disease are associated with MTHFR C677T. So we think cardiovascular disease, let's run a homocysteine level, and now that we know about folate trapping, we're gonna look at methylmalonic acid and form-aminoglutamate. Her homocysteine level comes in at 10, so the range for this is 4 to 15. Her MMA is elevated, and her FIGLU levels are elevated. So we can most likely conclude that she has macrocytic anemia because she has B12 and folate deficiency. We're gonna check in on methionine synthase if we're looking at genomes. And what about MTHFR? So she has the clinical presentation of having MTHFR, but MTHFR C677T increases levels of homocysteine. There are functional ranges. So we have laboratory ranges and functional ranges. The functional range for homocysteine is between 5 and 7. So she may actually have MTHFR C677T, which would be increasing her homocysteine levels, while also folate trapping, meaning that she would be decreasing her homocysteine levels. So here we have a picture of a quote-unquote normal level of homocysteine, and actually there's a whole lot of mess going on underneath of there. Okay, so now we're gonna look outside of the folate cycle. Okay, so we think in singularity often, we think about one cycle, it acts independently. Wish it were so, it's not the case. This is actually my favorite enzyme. It's called dihydrofolate reductase, and it converts dietary folate and folic acid into tetrahydrofolate, which is that substrate version of folate that we need in the body. Over here is your familiar folate cycle that doesn't go backwards, it only goes in one direction. That methyl donor gets handed off over to homocysteine. I do want you to take notice that the substrate for MTHFR can also participate in DNA synthesis. So it can jump over here and be converted back into dihydrofolate, and an offshoot of that is upregulation of DNA synthesis. So DHFR is the target for anti-cancer therapies like methotrexate. So folate is required for rapidly dividing cells. So if we are having issues with cancer, we want to limit that proliferation. Now hopefully you guys can see this image. So remember that DHFR is blocked by methotrexate. Up here we have synthetic folic acid. So start thinking about where you encounter synthetic folic acid. This enzyme is converting folic acid into dihydrofolate. But this is a very slow reaction. I want you to think about sitting in whatever city you live in beltway traffic at 6 o'clock, and there's been a 10 pile. You know what I'm saying. It's not going to come out today. Anyway, it's very frustrating when you get in that situation and you just basically want to pull your hair out. So that's what I need you to start thinking about when you think about folic acid and what kind of enzyme capacity we actually have to convert folic acid into dihydrofolate, which is our dietary folate. Dietary folate, freeway at 3 o'clock in the morning. It's perfect. It then continues to go on through our folate cycle to tetrahydrofolate, 5,10-methylene tetrahydrofolate to 5-methylfolate, which is the type of folate that can cross the blood-brain barrier. This is important because, as I mentioned earlier, this is the substrate for tetrahydrobiopterin, which then connects DHFR to the biopterin cycle. So our biopterin cycle is our neurotransmitter cycle that Jessica is going to talk in detail about that. Just remember that it can also go on for nucleotide synthesis. Now, you'll hear people talk about those that are on methotrexate taking levacorin. It's also called folinic acid, calcium folinate, or 5-formyl tetrahydrofolate. Those are all synonyms for the same thing. The reason that it's used is that it jumps in downstream, so below 5,10-methylene tetrahydrofolate. So this way, it can still produce 5-methylfolate and participate not only in methylation, but in neurotransmitter synthesis. So we have a 62-year-old man who's obese and eats our standard American diet. He has neuropathy in his extremities, depression, and his physician says, man, if you don't lose weight, you're gonna have a heart attack. He's trying to be healthy and is taking an over-the-counter 1 daily multivitamin. You look at his MMA, his FIGLU, and his homocysteine. So we're clinicians first, right? So we don't always look at labs, we don't always have genomes. So we're gonna walk through and just think, okay, this guy's obese, we're gonna start thinking about type 2 diabetes and inflammation. He eats a standard American diet, so it's full of what? Fortified foods. folic acid. He has neuropathy in his extremities, so we're automatically going to start thinking again about diabetes and possibly B12 deficiency. Now he's depressed. How are we going to connect that into what we're looking at? Well, there is a precursor to the monoamines, and again, that's DHFR. Remember, he's eating lots of folic acid, and down here we'll talk about how he's also taking folic acid, so he could be lifestyle inhibiting that particular enzyme. He's likely to suffer from a heart attack. So we've already talked about a SNP today that is involved with cardiovascular disease, and that's MTHFR C677T. And again, the multivitamin usually has about 400 micrograms of folic acid. So his MMA is 752. This is extremely elevated. So we want to start thinking about potentially our B12 recycling SNP, or we want to think about transcobalamin issues, et cetera. We want to look and find out why he has B12 deficiency. Interestingly, her Sfiglu is 2. So to be out of range, it needs to be above 2.2. This is a combination of things that we want to start thinking about folate trapping again. So anytime that we see an almost elevated or an elevated level of Figlu, you need to start thinking about folate trapping, especially given the fact that he has an extraordinarily elevated level of methylmalonic acid. He is not going to be able to convert that and use that properly. Now his homocysteine is 14. So with the supportive evidence that we have, is there a SNP that jumps out to anybody that they think he might have in terms of cardiovascular disease and homocysteine? It's going to be MTHFR C677T. And then lastly, we want to check his DHFR status to see if, again, it is an actual mutation in this particular enzyme or if there is a lifestyle-induced inhibition of this enzyme. So in summation, if you're folate trapping, you're going to have low homocysteine, high serum folate, high methylmalonic acid, and high form-aminoglutamate. If you have MTHFR C677T, you're going to have high levels of homocysteine and high levels of Figlu. Because remember, 5-methylfolate gets converted into tetrahydrofolate, but 5,10-methylene tetrahydrofolate through MTHFR is what creates 5-methylfolate to begin with. So if we have a limitation in MTHFR, we're going to have a limitation in our folates. If he has dihydrofolate reductase, he's going to have high Figlu levels and unmetabolized folic acid derivatives. So we can conclude that he most likely has competing SNPs of MTHFR, C677T, he's folate trapping, and he has some issue with B12 that is very serious. Now I'm going to let Jessica talk to you guys about Biopterin and DHFR. As we dance.
Yes, thank you, Christy. So we've already talked a little bit about DHFR and its role in folate metabolism. But really, one of the main takeaway points about this particular enzyme is that it's also integral for the production of tetrahydrobiopterin, or BH4, which is essential for the production of all of our monoamines. So again, here we're going to think about neurotransmitter metabolism. So if we think about exactly the role of BH4, it's very important for hydroxylation of all of our aromatic amino acids. So that's things like phenylalanine to tyrosine, tyrosine to dopa, as well as tryptophan to serotonin. So without these, we aren't going to be able to have the ability to create the neurotransmitters, and that's going to cause various mood disorders. The other piece that we can do with BH4 is production of nitric oxide from arginine. Again, we're not going to really talk in great detail about the urea cycle, but do know that that is also linked to it as well. Okay, so let's take a look at a pathway, because a picture is worth 1,000 words, and it gets a little dicey trying to follow these in the air. So if we think about the beginning of our pathway, we have phenylalanine right here, and we can convert this to tyrosine. So when we do that, that's going to require phenylalanine hydroxylase, and that has the cofactors of both BH4 and iron. Further, as we start to move downstream, we can move from tyrosine to dopa, and that's going to be using tyrosine hydroxylase, and again, the cofactors of BH4 and iron. So we see how integral it is to have appropriate DHFR function and BH4 as a result. One of the other things beyond, and we're going to talk about the creation of dopamine, norepinephrine, and epinephrine, as well as its catabolism later on, but I also want to point out that when we think about any one pathway or amino acid or enzyme, is that these aren't typically used only one place in the body. So what I want to point out here is that for tyrosine, it's very important to remember that it also is going to be integral for production of our thyroid hormones as well as melanin in the skin. And this is important clinically because sometimes we miss appropriate signals in the body. So when you're sitting and thinking, why is my client, for example, having hypothyroidism, here is a marker that we may need to be able to look at to see if there's an issue. Okay, so again, BH4, very important for production of our neurotransmitters. So accordingly, you're going to see its involvement in various neurological diseases, ranging from dopa-responsive dystonia to autism, Alzheimer's disease, Parkinson's, and certainly depression. It can also be related to insulin sensitivity and vascular disease. So it's important clinically that we actually look at the biochemistry in our practice. So things like measuring BH4 levels in the blood, or looking at the phenylalanine to tyrosine ratio. Organic acid markers are absolutely integral if you wanted to really understand what's going on neurotransmitter-wise in a particular patient. So looking at things like 5-hydroxyindole acetate, or 5-HIAA, that's the breakdown product of serotonin. Homovanillate, or HVA, which is the product of dopamine breakdown, and vanilmandulate, or VMA, which is the breakdown product of both norepinephrine and epinephrine. So Christy already alluded to the fact that BH4 and folate are intimately connected, obviously through DHFR, but it's really important for us to understand that if we don't have sufficient levels of BH4, that folate as 5-MTHF can actually stand in at the enzyme level. This is exactly why when we use folates in our practice, they can have an antidepressant effect. But I also want you to keep in mind that just because it may work and may provide some relief doesn't mean it's the ideal way for your biochemical process to actually function. So we do want to make sure that we actually have sufficient amounts of BH4 in our system. All right, so let's take a look a little bit more closely at functional testing and our catecholamines. So if we have our phenylalanine to tyrosine, that's using phenylalanine hydroxylase, and that requires iron to catalyze phenylalanine to tyrosine. If we think about this, if you remember, we have both BH4 and iron, so we want to look at our basic CBC, total iron and ferritin levels, to make sure that their status is not impaired. They don't need an actual SNP to cause this to have some issues. If you think about most women in particular, we have the predisposition to have iron deficiency anemias during our childbearing years. So keep that in mind, and certainly also certain diets may predispose towards iron deficiency as well. We also want to make sure that we're looking at urinary organic acid testing. So this is looking at things like HVA and VMA, as well as 5-HIAA, to look at dopamine, norepinephrine and epinephrine, and serotonin, respectively. Remember, if there are issues with these findings clinically, you're going to have problems ranging from depression to insomnia, sleep disturbances, anxiety, and even fatigue. So these are very, very relevant symptoms that you want to assess when you're speaking with your patients. Okay, let's take a look at the clinical picture. We have a 35-year-old woman who has been complaining of fatigue, binge eating, and depression, and she's been diagnosed with iron deficiency anemia and subclinical hypothyroidism. So we decide to take a look at neurotransmitter and amino acid levels, and we find that phenylalanine is elevated, tyrosine is low, HVA is low, and VMA is low. So what's going on here? Iron deficiency. We've talked about this in relationship to both the phenylalanine to tyrosine and tyrosine to dopa. So it's very important to remember that it's not just BH4, it's iron that serves as the cofactors for both phenylalanine hydroxylase and tyrosine hydroxylase. Low tyrosine, again, just another sign that we're not getting phenylalanine to tyrosine. And if we don't have sufficient levels of tyrosine, we can't possibly make sufficient thyroid hormone, and that's going to account for the hypothyroidism that we've been finding in this patient. Ultimately, though, it's going to impair her ability to produce her monoamines. So her dopamine, norepinephrine, and epinephrine levels will be greatly affected by this iron deficiency. Okay, so moving a little bit further, Christy already took us through some of the basics related to methylation and one-carbon metabolism. What I really want to talk about is really a more in-depth look at homocysteine catabolism. Methylation tends to get a little tricky for people to remember because they want to look at this entire pathway and memorize it in one great big piece. So I like to take it down into bite-sized pieces for people, and we look at the 3 possible routes of homocysteine catabolism. So our first route is through methionine synthase and methionine synthase reductase, which is our B12 recycling system. This is going to account for about half of the way that we actually get rid of homocysteine. And what this is going to do is it's going to use both B12 and folate to take homocysteine and convert it back to methionine. And then we have our shortcut route, which is BHMT, betaine homocysteine methyltransferase. And this is not a particularly frequented route for homocysteine catabolism. It's going to account for maybe 1% or less. Trimethylglycine and zinc are relevant for this particular enzyme. And then finally, we have our only true elimination route, which is cystathionine beta synthase, or CBS. And this is going to require vitamin B6 as its cofactor. So let's go ahead and take a look at what it actually is going to do. When we get through this pathway, we get glutathione. That's via the link at Transsulfuration. So let's take a look at a picture. So again, what we want to think of when we think about methylation is at the dead center, we have homocysteine. And let's take a look at those pathways. So we have homocysteine in the center. First, we can go up through MTR, MTRR, up back to methionine, and that's our first route. That takes vitamin B12 as well as folate because it's our connection to one-carbon metabolism, or the folate cycle. Here's our shortcut route, homocysteine to methionine, using BHMT. We also get the production of dimethylglycine from betaine in this particular reaction. And then finally, we have our disposal route, which is homocysteine to cystathionine via CBS, and that's going to require B6. This is a very important reaction because it's the only way we can truly get rid of homocysteine, and then it ultimately is going to go on to form glutathione. And then we're going to take a deeper look at CBS. I'm going to pass the mic back to Chrissy.
Thanks, Jessica. So cystathionine beta synthase. As Jessica mentioned, it's B6 dependent. It converts homocysteine into cystathionine. It has a product of hydrogen sulfide as well. There are upregulated variants and downregulated variants. So we're going to talk about basic science in just a minute on what that actually means. But for those of you who work in the pediatric population, I want you to take note that this particular enzyme is blocked by lead. So let's take a look at the picture over here. So we have homocysteine being converted into cystathionine via CBS. So if we go back and think about substrate, a catalyst, and a product, okay, for all my chemistry lovers in the audience, when you upregulate an enzyme, you upregulate the catalyst. So you're using the catalyst, you're depleting the substrate, and you're increasing the product. So in this case, we're decreasing the amount of homocysteine we have, we're decreasing the amount of vitamin B6 we have, and we're increasing cystathionine. So great, we have extra cystathionine. What are we going to do with it? Have a party? Not really. The body decides that it's going to take it over and turn it into ammonia. And this actually connects the transsulfuration back to that urea cycle that we can't have time to speak about today. So what it also does is that it puts strain on the other enzymes below it. So as we come down here, so through cysteine, it pushes through cysteine down to sulfide oxidase and to taurine. Remember that homocysteine is just methylated methionine, so we have methyl donors running through this system as well. The problem with this is not only do we not have enough substrate of cysteine to produce glutathione, but that when you upregulate sulfide oxidase or SUOX, which goes on for sulfation, it increases cortisol levels and glutamate levels. So you need to be thinking monosodium glutamate, okay? Excitotoxicity. So we look on a genome test and we say, okay, this person has a CBS upregulation, right? That's all we need to do? No, we need to use our clinical expertise. We need to check, in this case, for urinary sulfates. If we're between the 800 and 1,000 range or higher, then that gives you nice confirmation that there is CBS upregulation. These people are going to have sulfur drug sensitivities, halitosis, sulfur food intolerance, and brain fog from all of that extra ammonia. When we want to check for ammonia levels as nutritionists on an organic acids test, we're going to look for elevated orotate, citrate, and isocitrate. The last thing is that ammonia depletes biopterin. So we are also, if we're going to add to this clinical picture of elevated cortisol, elevated glutamate, elevated ammonia, now we also have neurotransmitter instabilities. So we're typically going to have an elevated xanthuronate level, which is our functional marker for B6. You're going to also see high taurine, and you'd find that on an amino acids test. So what are we going to do about this? Well, first of all, we think, okay, ammonia, let's reduce the protein intake for a little while and see if that helps. Second of all, you're going to think, okay, sulfur donors, we're upregulating this particular cycle. Let's think about maybe removing some of those sulfur foods. So we're thinking about eggs, we're thinking about cruciferous vegetables, and so on. Now, this is a therapeutic diet. As Dr. Lipsky mentioned yesterday, we do not have diets that last forever. So we don't want to eliminate sulfur donors forever because then we won't be able to make glutathione. Lastly, we're going to supplement with molybdenum, which is the cofactor for SUOX. Now, here's the downregulation. So homocysteine is being blocked. So again, we're going to have our substrate, our catalyst, and our product. So in this case, our substrate level is going to go up because it's not able to convert into cystathionine. Could this be an enzyme issue? Sure, it could be an enzyme issue. It could be a cofactor issue. It might be B6 deficiency. So that's something that you want to look at. But you also want to think, okay, elevated homocysteine, what else is that related to? It's related to MTHFR-C677T. So as good clinicians, you need to go back and check and make sure that that's not actually the reason that you have high homocysteine levels. Now, in this case, we're going to have not enough substrate of cysteine. So cysteine is our precursor molecule for glutathione. So you want to consider not only upregulating your enzymes that are being blocked with their cofactors, but you also want to think about N-acetylcysteine. Now, you can have a SNP in one area of the body that does not affect the other. So in this case, as Dr. Bland mentioned, there's hypertension and cardiovascular disease in one tissue, but in another tissue, there's actually a decreased risk of breast cancer for this particular SNP. So I need you to stop thinking about good SNPs and bad SNPs and start thinking about what tissue they are interacting with. So I'm going to do a quick case study. We have a little boy with ASD and intellectual disability. He's been on the GAPS diet for 2 years with no noticeable changes, and he has foul, stinky gas and often appears to be bloated. So the GAPS diet is full of cruciferous vegetables, right? So lots of sulfur donors. He has foul, stinky gas and often appears to be bloated. So that's associated with a CBS upregulation. He's also been diagnosed with autism. So I want you to think back to those associations in the upregulation. When there's excess glutamate in the body, we have excitotoxicity. We also have excess cortisol. We also have excess ammonia. So the clinical picture of autism can certainly fit into this particular upregulation. You check his xanthuronate because we want to make sure that we're doing what we need to do, and it's elevated. His cystathionine levels also lend more credence because they're elevated. Methylmalonic acid is also elevated. So we think CBS upregulation and possibly methionine synthase. So you expect a homocysteine level to be low, right? And CBS upregulation. Should you check it? Yes, of course. In this case, it's a level of 2, which is low but not completely 0. So The methylmalonic acid being high in this case confirms that there's actually a homocysteine catabolism issue, because if you remember, Jessica mentioned there are 3 routes of homocysteine catabolism. All right, now back to Jessica for neurotransmitters.
Thank you. So earlier on, we talked about DHFR's function in production of BH4, and we can see that, I think, even more clearly here in the conversion of BH2 to BH4. But what I really want to actually take a look more closely at this point is the breakdown of the neurotransmitters. Certainly their production is really important when we look at mood disorders, but it's just as important how quickly we're able to break down the various neurotransmitters. It's sort of like Goldilocks and the 3 bears. This bed was too soft, this bed was too hard, and this bed is just right. And that's exactly how it goes with neurotransmitter function. So if we take a look at our phenylalanine pathway, which is right through here, and we can take a look at dopamine, we have 2 possible ways to go with dopamine. The body can either decide that it's time to break down the dopamine directly, in which case we can take dopamine to homovanillate using both the COMT and MAO enzymes. And we'll talk a little bit more about those enzymes in a minute. But we can also go through dopamine beta hydroxylase and convert dopamine to norepinephrine. And then norepinephrine can go via COMT to epinephrine. And both norepinephrine and epinephrine are broken down by MAO and COMT as well in order to create vanilmandulate, the urinary organic acid. When we look at our serotonin metabolism, we have production via tryptophan to 5-hydroxytryptophan and ultimately serotonin. And this is also broken down by our MAO enzyme to 5-HIAA. So let's take a look at catechol-O-methyltransferase, or COMT. The cofactors for this particular enzyme are SAM, our universal methyl donor, and magnesium. The takeaway of what our COMT enzyme is going to do, it's going to break down dopamine, norepinephrine, and epinephrine, but it's also important for transferring a methyl group from SAM to our catecholamines, and catechols also in our foods, so things like green tea and potatoes, antioxidants like quercetin, and even estrogen, which is a hormone catechol. When we look at clinically what's going on with our COMT SNPs is because of the effect on the dopaminergic tone, they are related to higher anxiety levels, although on the bonus side, people tend to have also higher executive function. And so it's this sort of dichotomy between being able to go after and do what you need to do because you're more cognizant, but on the flip side, you may not be able to get the mind to quiet down. Because of the cofactor being magnesium, clinically, one thing that we want to do is take a look at RBC magnesium levels to make sure that status has not been affected if someone has the SNP, or we might think that they have this SNP. So let's take a look at a clinical picture. YM is a patient who's a workaholic with tendencies towards perfectionism, occasional anxiety, and insomnia. She also suffers from estrogen dominance and has a past history of 2 uterine polyps removed by polypectomy. The clinical association of estrogen dominance is supported by symptoms of occasional spotting between periods that's alleviated with the use of DIM. Her chief complaint is that her brain is always spinning, which has made it increasingly difficult to fall asleep and stay asleep. She also tells you that another doctor had recommended B vitamins for energy, but that she did not tolerate them and they made her extremely anxious. So what's going on here? Well, if we take a look at the actual blood work, we see that serum magnesium is lab low at 1.2. And this is really uncommon because our levels in the blood of magnesium are very tightly controlled. So this is a significant strain on the magnesium store and really does point towards a COMT SNP, particularly when we take a look at the symptoms. High anxiety, insomnia, intolerance of B vitamins, particularly the methylated B vitamins, because that's going to increase neurotransmitter levels, particularly dopamine, norepinephrine, and epinephrine, which if your COMT enzyme is not functioning appropriately, you'll not be able to actually break down. And then also estrogen dominance will lead to that. All right, let's move into our monoamine oxidase A, or MAO-A. This particular cofactor is FAD, which is assisted by the vitamin riboflavin. And this is important for the deamination of all of our amines. So that's dopamine, serotonin, norepinephrine, and epinephrine. But it's also xenobiotic amines, things like heterocyclic amines in our meats, tyramines, and histamine. It's also important to see how this connects tryptophan via methylation, and we can take a look exactly at how this occurs by looking at urinary amino acid levels. So we can see whether there are disturbances to things like our tryptophan level, or even going back into our COMT patterns looking at phenylalanine and tyrosine. The big takeaway with this particular SNP, as Christy talked about with the CBS C699T, is that it is an upregulation, meaning it's going to work better than one would expect or want. And so what we see is that there's a high correlation with depression. And this is particularly relevant for our postmenopausal women, where we tend to see much more depression than even pre-menopause. Why? Well, if we have a fast-forward SNP, and this is breaking down serotonin, it's going to mean that you don't have sufficient serotonin. You have a higher requirement for the substrates that produce serotonin. Let's take a look at our serotonin metabolism in a little bit more clear graphics. So we have, at the start, we have our L-tryptophan going through tryptophan monooxygenase, and that goes to 5-hydroxytryptophan. And that's going to require BH4 and iron. Your 5-hydroxytryptophan is then converted using B6 to create serotonin. And then we can see our monoamine oxidase with FADase, the cofactor, to allow for the breakdown product of 5-HIAA. All right, we're going to take a step away from methylation because I really couldn't talk about our neurotransmitters without talking about GABA. So if we take a look at the enzyme that's really important, it's glutamic acid decarboxylase, or our GAD enzyme. And this is the enzyme that's going to take our excitatory neurotransmitter glutamate and convert it into our inhibitory neurotransmitter GABA. And that's going to require vitamin B6 as the active form, P5P, or pyridoxal 5-phosphate. This is really associated with panic attacks and anxiety. It can cause decreased levels of vitamin B6 in the body. And then it's also really important to point out that this particular enzyme works in the pancreas, and it regulates the release of insulin. So what's the takeaway? What's going to happen? Well, we see even in twin studies that there is a genetic component to anxiety. It's about a 48% linkage to heritability of panic disorder. And it really can explain why GAD is linked to both neuroticism and mixed anxiety type. So if we take a look exactly what's going to happen, anxiety, panic, increased blood glucose levels and hemoglobin A1C with decreased insulin. What I like to think of this as really diabetes type 1.5. You may come in and think type 2 diabetes, but you'll know something is a little bit off when you see the actual numbers. So how do we tell the difference? Well, finally, we have a 35-year-old client who's had a recent panic attack at the local mall, just feeling anxious a lot, and we have some testing that comes back. Xanthuronate, or our B6 marker, is elevated. Magnesium levels are normal, and insulin is functionally low with glucose elevated at 115. So what's going on? Well, we see a pattern here, right? Magnesium is normal, so we don't have COMT issues, but B6 is a problem, and blood sugars are also a problem, and that really is going to point back to GAD and not COMT. So I really hope that what your clinical takeaways are from this is that you're going to be able to use this information to look at methylation, neurotransmitter synthesis, and homocysteine catabolism more readily in your practice. We need to remember we don't treat SNPs. We need to look at all of the clinical pieces and put them together and use the SNPs and our blood testing and organic acid testing and other markers to really validate them and to look at a fuller clinical picture. We thank you so much for your time.
Thank you.